Welcome. My name is Maud Brahmi. I'm a division manager here with the Fresno County Department of Behavioral Health. And this is a overview of Proposition 1 information as it applies or is being addressed by Fresno County. This is a recording to allow anyone who's viewing this to get information about what is Prop 1, what is our understanding of Prop 1 and its impact here locally in Fresno County, and what some of our next steps will be. We did host a live in-person session on Monday, April 29th, I believe it was, whatever that Monday was. This is that same presentation. However, we did not record that one. This one is being recorded and will be posted to our website so individuals can come back and see the information on the PowerPoint, and or if they have wanted to kind of review or see if they missed anything. And we'll also be utilizing our MHSA page here, FresnoMHSA.com, for putting things up on there, such as frequently asked questions related to Prop 1, additional Prop 1 updates, which we'll get into, and just future meetings related to MHSA and Prop 1 as well. So, our first slide. Prop 1, or Proposition 1, that was the name given to the Behavioral Services Act. The Behavioral Services Act was made up of two components. One is a bond measure, which is about $4.4 billion. That's billions with a B. And to modernize MHSA, which I'll dive into each of them. Just to be aware, when MHSA, the Mental Health Services Act, first came into inception as a voter-driven initiative in 2004, it was on the ballot as Prop 63. The numbers, though, for legislative and policy efforts are recycled. So once a number is used, like a Prop 1 or Prop 63, it's not retired and it can never be used again. You know, within X amount of years, they'll reuse that number again until it becomes a law. So when you see things like Prop 1, make sure, and you're trying to read up something on here, make sure it's this Prop 1 related to Behavioral Services Act, not a Prop 1 for some years back. In the future, if you see something Prop 1, 5 years from now, it may not be in reference to this. So while we say Prop 1 and we used to say Prop 63, we really want to get into utilizing more of the Act itself, which is the Behavioral Services Act. And so I'll try to say throughout this Behavioral Services Act rather than Prop 1, just because at some point Prop 1 will go away, but Behavioral Services Act will be what we'll be working with. So back to that. Proposition 1 proposed two parts, two functions under that Proposition. One was to, like I said, modernize and revise the Mental Health Services Act into the Behavioral Service Act, and the other one was a $4.4 billion infrastructure bond measure. The $4.4 billion is broken up into a couple of different components. About $1 billion, a little over $1 billion, is set aside specifically for veteran housing. About $1.5 billion has been set aside for grants. For housing grants. Of that 1.5 million, about 30 million is set aside specifically for tribal communities, and just under $1 billion has been set aside specifically for persons at risk of homelessness who have a behavioral health condition, which could be substance use, mental health, or both. Just some of the things that for those bond projects that I mentioned. As of right now, we have those broken out into what the amounts are, but how much each county would get is uncertain, has not been identified yet. We know it'll be through competitive grant processes, so it's not going to be likely that it'll be a distribution to each county, but counties would have to apply. A lot of these bond measures and the funds set from the bonds are not limited just to counties, so there may be other entities that are able to also apply and bid for these. We don't know yet if it would have to be something done in collaboration, if it would be done specifically by an entity, how those application processes will work. But we do know that they're going to be through a competitive process, and so we need to really stay aware and be proactive in opportunities to pursue these, because if it is a competitive grant, we don't want to sit and wait and hope that we get an award. We want to be diligent and vigilant in our efforts to get those, and Fresno has been really successful thus far in securing a lot of grant funding for housing and some of the efforts around that. One of the other things that the bond measure seeks to invest in is one-time funds to create 5 what they're calling regional treatment campuses. Where these campuses would be, other than in 5 regions in the state, is broad. So central region, we don't know where it would be. Would it go based on availability of land? Does the county have to bid on wanting to be the host? Is it based on cost? how that will be rolled out. Additional questions as far as what about the cost for sustaining, maintaining, all of those things. So there's a lot of unknowns with that. These regional treatment campuses are meant to be inpatient, but they've also talked about them having levels of step down. So there may be on the one campus ranging from things that might be more of locked facility for somebody really acute to more step down opportunities. We in Fresno County are going to selfishly hope and want to pursue that one of these 5 regional campuses is actually here in Fresno County. We have a need for it. We also want to make sure that we're keeping the people that we're serving close to the resources, their supports, family, things of that sort. So there's a lot of benefits for that being here. But again, as of right now, we don't have details on what that's going to look like, when those funds will be released, what the process will be. And so it's just more of being alert and aware and continuing to follow the evolution of these bond projects to see when there will be opportunity for us to pursue some of those. So you'll see on screen just some information about the bond measure, which I talked about. We don't know where those treatment beds will be located. There is a number set, for example, on the number of units. They hope to try to address and provide services to the number of beds and persons to be served, but that we don't know if that's going to be divided equally across the 5 regions. Will it be different by regions? How does that work? Does it go first come, first served? Does the county get a certain allocation? All of those are things that we don't know yet, and so we're hoping, over in the coming months, we'll get some more information. Let me go to our next slide. So now I'm going to go to the second facet of the Behavioral Services Act, Prop 1, which was to modernize or update the Mental Health Services Act. So the first one, the Mental Health Services Act, will now be called the Behavioral Services Act. A little background: when Mental Health Services Act, or MHSA, was developed and voted on by voters and approved back in 2004, it was intended to close the gap in our system of care, which is an example would be you might provide medication and therapy to someone, but what happened in terms of like the other needs they had? What if they couldn't get to their appointments? What if they were unhoused? What if they needed additional support? So the Mental Health Services Act really closed that gap. The areas that our system previously could not fund but needed to address the whole person were better addressed. To be transformational, part of the big efforts around Mental Health Services Act was to invest in prevention and early intervention, doing a lot of work around stigma reduction, education, timely access, things of that sort. It was also to be innovative, allowed opportunities, and it has for the past 20 years to create innovation plans and try to pilot and come up with new ways and methods and service models that could have a better impact on outcomes. And it was, like I said, focused on prevention, and it had shifted to really that upstream prevention of if we can do a better job on preventing some of the challenges people face as a result of their mental health condition or something that could lead to a crisis, we would just alleviate a lot of those issues and be more timely in responding to someone's mental health challenges or needs, more in within a few months, few years versus the way it had been in the past, where it may have been several years or something like that. It was really to reduce prolonged suffering. So that was the Mental Health Services Act. The Behavioral Services Act, so in addition to having a new name, is going to have a lot of new components, and it's going to change the funding category and focus. The Behavioral Services Act is set to go into effect for fiscal year 2026, 2027. So we have, on paper, if you look at it, about 2 years, but really we're going to need to be working a lot sooner and a lot quicker for that. The Behavioral Service Act, the new plan that'll drive that, is going to be not one just for Behavioral Service Act, but the new 3-year plan will be for all services, which I'll cover in a minute, related for the county behavioral health. So it's not based on funding, but everything that the county does. And so a more robust plan with more requirements would probably take longer. On average, like I said, it takes us about a year to do a 3-year plan with the community planning, writing, analyzing the data, going through the different steps to get it approved, public comment, various boards, things of that sort. And so now you're talking about a plan that's going to be for the entire system. So we do want to start working on this sooner than later. So based on that, we're looking at, within, we need to have about 18 months to the work versus 12 months. And so we're working with our partners, associations, other counties, state organizations, agency to try to get as much info and ask for as much timely info as possible so we can better plan for that transition. So here's a few clarifications that you'll see on the slide. Prop 1 does not provide new money for services. That is very important for people to understand. There was a lot of misnomers, in the past year that Prop 1 is going to, create more money. There's going to be more money for housing. There's going to be new money for SUD. There is no new money. Prop 1 is still going to be driven based on a 1% tax on annual incomes of $1 million. So if someone makes $1 million this year, they will pay 1% tax that'll go into MHSA. If they don't make $1 million the next year, they're not going to do it. So the revenue really is based on the economy. So it's which we'll get into a little later. So it is a changing or volatile funding source, as it's been called. So first clarification: the Behavioral Services Act, which is a result of Proposition 1, does not provide new money. Current funding is being reallocated into different categories, which I'll go into and show you a graph shortly about that. These funds are still used to provide Medi-Cal match. So a lot of times, well, not a lot of times, when you're doing Medi-Cal, the money is not just, here's your Medi-Cal, you have to put up a match. So, if you put $1 up, then you get $1 back from the feds. So that's kind of how you do the match. So it's like if you're wanting to draw Medi-Cal, you've got to put something up. So historically, we've used MHSA also to support that Medi-Cal match. So still one of those areas that we focus on. And BHSA is still going to be the funding of last option. So it's not going to be like you have Behavioral Services Act funds, go do services. It's, hey, can we utilize Medi-Cal? Can we utilize other funding and resources? How can we leverage Behavioral Services Act dollars to address the need to fund the services versus relying on it solely? Really, so it's going to lead to more braided funding, basically. It's not just an MHSA plan, which in the previous slide I talked about, but it's rather county-wide plan. So if you were familiar with the Mental Health Services Act, MHSA, we would do a 3-year plan, and then every year we would do an annual update, and that was related specifically to programs and services funded by the Mental Health Services Act. Under Behavioral Services Act, the county is going to be required to create a new 3-year plan for the entire behavioral system of care, regardless of the funding, whether that's federal funds, state funds, grant funds, anything. Any funding that you have for behavioral services will now be involved and included in this plan. So it'll be a lot more robust plan. It'll be a lot more integrated plan. We will still have and continue with the community planning process. We will still have a robust stakeholder process. We will still try to engage our rural communities and special populations. We're still going to try to make sure that those forums are at times and in different venues and places that can be accessible, really have community involvement in that. We're very proud of our efforts and want to continue doing that. There will be a new and increased reporting requirements with these plans. So the plans are now going to require more data, better data, being able to have measurable outcomes. How many are served? How do you know this service is working? Can you measure that it improved the lives of individuals or address whatever the reducing homelessness, increasing, activities and people reaching out for help, reducing hospitalizations, all those things, as well as costs. Like I said, the plan requires for every cent that is spent to be tracked and monitored. So we're going to have to look at what programs were funded, how much, what was the cost per person, what does the data say, what was the impact, did it work, did it not work, is it cost effective, is it not? So these are all new things. Well, I don't want to say new things. These are all things we've been doing, but they're new things in terms of that are going to have to be reported on. So these were more of practices that you do in administration, but now we'll have to report them as part of our plan and reporting out. There's no changes in the source of the funding. It's still going to be that same, like I said, 1% annual tax on annual incomes of $1 million or more. The volatility has not changed. Again, right now we know the state is developing a budget in light of their deficit, and so when there's a large deficit at the state level, that has an impact on the local level. When you have upturns and downturns in the economy, those things have an impact on what was Mental Health Services Act and will be Behavioral Services Act. More prosperous times, you're going to have more tax revenue. In times where it's leaner and a little more challenges or economic downturns or even recessions, then there's going to be less revenue coming in. So those are things that we just need to be aware of. It's not new money; it's the same money we've had. Just the pots or how you use them has been changed. So let's go into those changes in funding categories. So if you look at this graphic that's on your screen right now, you'll see 2 buckets. There's one bucket that you see on the left, which is this prior MHSA funding component. So MHSA, when it started out, had multiple components. It was, for the first 10 years, there was capital facilities and technology, workforce education and training, innovation, community supports and services, and prevention early intervention. After 10 years, it was the primary focus with 3 funding categories: innovation, prevention, early intervention, and then community supports and services. And it was left to counties if they had the money, if their stakeholders were in agreement, if they had the capacity and wanted to still invest some of the monies into workforce education training or capital facilities and technology. So for the, in the recent years, that is the chart that we had. So out of the total MHSA, the state had a 5% admin cost. Then the rest came to counties. Counties had innovation, 5% for innovation. They had almost 20%, a little less because someone went to innovation for prevention, early intervention. And then they had the rest for systems, community supports and services. And of that, half needed to be utilized for full service partnerships. So the new pie chart on the right is going to show you what the new funding category is going to be. And I know there's a lot of slices. Look at them by color and the tone, not the actual individual colors. So the things that are shaded purple are all one, even though they're in 2 different tones. So the new funding category is going to be, the state is going to have a portion of the MHSA funds that they need to utilize from the beginning. So the state has reduced its admin take from 5% to 3%. But they are adding a statewide behavioral workforce component at 3% to try to fund and support some statewide initiatives to try to address workforce shortage and challenges. How that's going to work in terms of, will it be, supports to individual counties? Will it be done by region? How that's going to work, we don't know yet. Those are, I think, things that are going to have to be explored, discussed, and more information, will come out on it. I just want to remind people that in the Central Region, Central Valley, we had a mental health shortage challenge pre-pandemic, almost 20 years. And so hopefully with some of these statewide initiatives, they will address those disparities by looking at, where the need is and where maybe there have been some historic capacity needs that might be able to support some of those workforce needs. So there are current workforce, some state-funded workforce efforts. This would be, again, something along those lines that could, at this point, we don't know, be anything from recruitment, tuition reimbursement, stipends, we don't know. But it would go to a statewide effort. And then we have state-based population-based prevention. So that's key because if you see on the chart on the left, we had PEI, prevention, early intervention. And if you look on the left, the only place the word prevention appears is in that 4% that's with the state. So the state is going to do prevention services under Behavioral Services Act starting in 2026. They're going to be working with the California Department of Public Health to do that. Again, we don't have information yet in terms of what that's going to look like. So is Department of Public Health going to run programs itself? Is Department of Public Health going to contract with providers? Is Department of Public Health going to do regional programs, county-specific programs, statewide programs? Will they be through grants? Will they be pilots? We don't know. So I'm sure there'll be questions of what does this mean for prevention programs? We don't know as far as what the state is planning. We just know that with the new Behavioral Services Act, a lot of prevention or things that would be deemed prevention would have to be reassessed and reclassified because it would probably fall under the requirements that the state has, which are not things that the county would be doing. But again, that's all information. We're waiting on updates to regs, information, how things are going to be defined, etc. You'll see the 2 purple shaded slices of the pie, which are both housing. So there's the housing component, but the housing component itself is also broken up into a couple of areas. So while we have housing, there's going to be about 50% of housing that's going to go to, where did I lose my info? 50% of the housing will go for individuals that are chronically homeless, with a focus on encampments, getting people into homes, getting them off the street. Chronically homeless is a definition. They're going to be utilizing the federal definition for chronically homeless to deem that. We know in working with individuals that are unhoused or receiving mental health services or substance use, They may not all always fall under that definition of chronically homeless. So again, those are things that we're working on to have a better understanding. And what does that look like? What does that mean? A portion of that housing is also going to be utilized for 30% of the funds will be used for housing. Of that, 50% will be used for, like I said, chronically homeless. About 25% is going to be utilized to support individuals who are at risk of homelessness and have a mental health or substance use or co-occurring disorder. So it's really try to do some preventative work utilizing housing first model and concept. And then there'll be up to 25% that'll be set aside that could be utilized for capital projects to build housing. As you may know, in Fresno County, for example, we have a challenge, and I think in a lot of places in the state, we have a challenge with the housing inventory. We have a challenge with affordable housing. And so, in order to address individuals that are unhoused and need treatment, we're also going to have to build up inventory. So there is some funding for that there. If you've been involved with housing projects, construction projects, they don't happen overnight. They do take some time. So, these won't come online the day after, the state releases the money. They'll take some, it'll still be a process for us to get those housing up. But those are going to be the things that are going to be focused on. I do need to provide a quick point of clarity. Let's go into the housing chart, guys, and I can show you a little better here. Should have probably done this a little sooner for you all. This one is a bigger pie chart, and you can see this is specifically for housing. So as you can see, 30% of the housing funds, like I said, of the overall funds have to be used for housing. And this is the point I want to make. When they say for housing, they mean specifically housing, roof. So it's things like rent, deposits, cost to get into housing. It does not include things that could come up under like a supportive housing model. It does not necessarily mean all of the navigation and supports that go into that. So it's got some very specific criteria. You'll see on this PowerPoint that it says see provided packet or visit link here. When this is posted to the website and the PowerPoint is posted, we will have that link active so that you're able to click on that link and get a little bit more information on what they're talking about, limited community supports. You'll see there the 50% for, like we said, chronically homeless and encampments. And part of that work is going to be doing direct outreach and engagement to individuals in those encampments and working with them to build relationships, to build trust, and to make the necessary contacts so that a person is willing and open to going into care. And then you see in there, like I have that on the screen, you can probably see clear, they're green for the capital projects. So those are things that we would be able to use starting 2026. We may use up to 25% of the funds, but not beyond that. And then after, in about 8 years, in 2032, there may be options to grant adjustment percentage. So that might be, 8 years from now that we submit and say, hey, we know what, we need to utilize more money to build. We need more money actually to support individuals in encampments. Or, hey, we've been able to make progress in one area, and we would like to have an increased focus on the area for, preventative housing. So those are all things that will come in the future. We don't have specifics yet. And that's what you're going to hear as a theme over and over again. A lot of the stuff is very general that we're presenting to you. As more information becomes available, as we start to develop these plans, we will definitely be sharing through these type of mediums more information. So the next slide is going to be the full service partnerships. If you've been around Mental Health Services Act for a while, you will know full service partnerships, otherwise known as FSPs. If you're new to this work with Behavioral Services Act, full service partnerships were the category for the highest level of care that was not residential or inpatient that we had for mental health. They utilize and were based off real closely of the ACT model, Assertive Community Treatment Model. Full service partnerships really try to provide that wraparound whole person care for individuals. It's been a model that's been really effective in some forms of it. The closer we get to really best practices and maintaining those programs to fidelity, we really do see some positive outcomes with it. And so the state decided to continue with the FSPs and actually increase a little bit more of the allocation for the FSP. So prior to Behavioral Services Act, FSPs were about 32% of our total MHSA budget. As you see on the slide, it's about 35% of the total budget. It'll actually be a little bit more because FSPs were utilizing, they were serving the whole person. So the FSP programs provided service to the individual, the supports, the housing, things of that sort. Housing being its own separate component means some of the funds that may have been utilized for housing in FSPs will be able to utilize to serve more individuals. One of the new things that are required is that counties are going to be required to have at least one ACT, assertive community treatment model, to fidelity, and it's very, clear that the language is to fidelity. It's not an ACT-ish. It's not like, well, we have an FSP based on an ACT model. It's going to need to have one ACT. That does require some additional cost to meet its smaller caseloads, a multidisciplinary team. There's a lot of capacity challenges in counties to have, for example, an ACT team to fidelity. So there would be a need to do that. But we believe that the changes and flexibility within the FSP is going to allow us to do those. The FSPs will continue to provide services to individuals at that full service partnership level, but will also include our continuums of care that we have, which are for individuals still having a serious mental illness, but maybe their level of acuity has moved from an ACT to an FSP, and maybe they're stabilized and doing well to where they can move down, but still have a chronic condition. Those would also be considered services under the FSP funding umbrella. So it won't be FSPs doing FSPs only, but FSPs and continuums or those high-level care services under the full service partnerships. We were going to continue to work on improving our full service partnerships, our full service partnership providers. A number of them were involved with us in a statewide project to evaluate and assess full service partnerships. I believe some of that work was actually what informed the legislation. And we've seen some recommendations that we think once implemented in our FSPs are going to really help our FSP even be more effective and really be more responsive. And so in the future, as we move forward and plan and design and redesign and develop new agreements, those things will be applied there. But the full service partnership is really the key treatment area focus of the full service partnerships. One of the things also with the Behavioral Services Act is that counties can utilize FSPs to provide substance use disorder services. There are some challenges with that at this time in that FSPs have not been utilized to address specific substance use only challenges and needs. The system would need some design. There would need to be some adaptations, some piloting. But the good thing, it doesn't say that you have to use FSPs for SUD. It's just saying that you may now use it. So if there's a way to do it, that'll be something I'm sure counties will explore. We in Fresno County have a number of FSPs, including an FSP that works with individual adults with co-occurring disorders. So we're already addressing, a lot of challenges in individuals that might be facing in a way to be more effective in serving our community. The next slide is the behavioral health support and services. So this one is the other kind of chunk of the funding source. Like I said, there's three buckets, which is housing, FSP, and the other one is this behavioral health services and supports. This makes up about 35%. Well, not about. It is 35% of the behavioral health funding. It is the funding bucket that has to support all of the efforts that the county would do. That's not FSP and that is not housing. We know over the next 12 to 18 months there'll be a lot of discussions as we get more information and assess programs and services and figure out what does this look like, because honestly in the past what would fall under the behavioral health services and support today in the past on the MHSA was about 60% of the funding. As you can see on the screen, it's about 35% of the funding, so it's about half. So it does make it hard to do everything we were doing before. But we're also going to evaluate and look at all our services. Are there other services and programs that could be funded other ways? Are there ways that we can look at cost savings? Are there programs and services and things that we're doing that cannot be addressed through CalAIM and Medi-Cal payment reform? Are there services and resources that have, while they've been great, address the need that they needed to and shift our focus or things like that. So there's a lot of initiatives coming in from the state level that we hope we'll be able to utilize and leverage to close gaps. Any workforce, facilities, innovation, anything like that is going to need to come out of this bucket. Now the challenge with this bucket is, if you see, it's half is going to be utilized for whatever you are identifying through your assessments, through your stakeholder process, through your capacity, it's going to be that. The other half of the funding has to be set aside specifically for early intervention focused work. Half of that early intervention work is going to be early intervention for adults. The other half is early intervention for youth. Early intervention, the way it has been defined in the past, is a diagnosable, so it's a SMI diagnosis, so severe mental illness, serious mental illness diagnosis, with the intent of really addressing that person at that early onset first diagnosis, getting them the supports and services they need, and really stabilizing and building up their support over a couple of years so that they don't end up needing hospitalization. They don't end up needing maybe FSP level of care. They don't end up experiencing a lot of prolonged suffering and unnecessary challenges because intervention was not done early enough. How is that? If that's going to be the same way how they're defining it, how it's going to be done, we don't know yet. What is going to constitute an early intervention, we don't know yet. Other than there will be, the state will provide a list of what they're going to say are approved early intervention programs that county can select for early intervention. My understanding is that I don't know if it would be excluded to that because there's opportunities for, in addition to those evidence-based, to community-defined practices, which would be newer, maybe non-traditional approaches. But they will provide a list and that you'll have to work off of. We know that there's challenges sometimes when you look at evidence-based programs. Obviously, they're evidence-based and effective, but they don't always necessarily mean they're effective for everyone. They're not universal usually. They're specific for a population, an age group, in a setting, things of that sort. And or sometimes evidence-based projects require certain capacity. Like, yeah, this program really works well and it's really effective, but you've got to have 5 psychiatrists, 5 psychologists, 5 therapists, 5 nurses, and 10 peers. And if you're in a county or a program that's like, well, not only do we not have 5 psychiatrists, 5 psychologists, 5 therapists, 10 peers, etc., but we don't have the money, if we did have that many people, to fund those just because of the cost. So those are, I think, why they're going to provide a list. So instead of saying you must do this program, I think they're going to provide a list to allow counties to try to find what are early interventions that might align best with their needs. But there even then may be some limitations, but there's also opportunities with community defined, which were not in our MHSA, in our previous MHSA iterations of either especially mental health services or even prevention services. And now under Behavioral Services Act, we have seen a lot of language in there calling for and supporting the use of community defined in these different funding areas. So it definitely does give us some options and opportunities. You'll see the last one in there, workforce capacity. So counties are going to be required to measure and assess what the workforce gaps are. So that's not just for the county, but that's our county system of care. Where are the gaps? And then addressing strategic plans on how you're going to address it, how you're going to close those gaps, how you're going to fill those vacancies in your system of care. And so if you're deciding to do an initiative or study or something like that, that would also need to be funded out of this pot. So it does provide a broader, in some sense, use of things that we could do. Before we couldn't do SUD only on the prevention, SUD being substance use. We didn't really, we had the WEP, but we weren't necessarily looking at gaps in the service or having to track those. It was more how do you develop and build workforce. And I think now it's given us a lot more options, but it does put a lot of requirements on, yes, you have more options, but you must do these things. You must have these protocols. You must report these outcomes. We need to see effectiveness in this area, which are not bad things. It's just going to require some additional capacity, I think, for counties and our system of care to be able to do those things. But yes, it does provide opportunities for CDEPs, community-defined evidence-based practices, which I am a fan of. So this next part, I touched on it a little bit earlier, but prevention as the way we currently have it is not going to be something funded at the local level. It's going to be statewide, and as I said a couple slides back, it'll be through the State Department of Public Health, but it has not been identified how that's going to be done. Will it go to schools? Will it go to counties? Will it be open for organizations to bid? Will it be through grants? Will it be through ongoing contracts? Will they be regional partnerships? We don't know. but it will be done at the state level, and most of it will be done through the California Department of Public Health. It will not be a local funding category. The state is going to utilize also some of the how I'm trying to look where we have it on here. The prevention activities that are services provided to individuals would potentially be something that could be provided under that early intervention, Behavioral Services Act component. Things that are very broad. A lot of the work we've done in certain areas over the years of suicide prevention, a lot of the work we've done in stigma reduction, right? A lot of things we've done to, prevent school failures or dropouts or things like that. Those are very broad population, not an individual one-on-one service. Those would be shifted and required to be done at the state. Locally, you may have something that kind of is a prevention, but it would have to be like a one-on-one. And if you're doing that intensive one-on-one, it may fall into early intervention, not prevention. So that's kind of why you don't see us, saying, well, we can still do prevention, because it's going to be very narrow. And the funding for prevention is going to be at the state level, so it's still a lot of opportunity statewide to do that. Innovation, before innovation under Mental Health Services Act has been its own category with 5%. It has its own process. In order to be able to access the funds and fund projects, you do need to develop an innovation plan, has some specific requirements from the state, go through stakeholder process, 30-day public comment, having it approved. You cannot spend the money until you have a plan approved. The funds were one-time funds for 3 to 5 years. Really should not have been utilized as seed money, because you didn't have to look at sustainability. Counties like us in Fresno have utilized those funds for more pilots, research, demonstration projects, things of that sort. So you'll see on there, it doesn't say no innovation on the slide. It says no longer a separate funding source. So counties can still try to pursue innovation projects, and some of the things in the legislation talk about continuing to try to be innovative in everything you do. So there's opportunities to continue to look and expand and advance innovative opportunities in our system of care. It just won't have a specific dedicated funding category and a specific process by which it has to be approved. Substance use disorder, I touched on a little bit in the last slide. A new area that is able to be served by the Behavioral Services Act, formerly Mental Health Services Act. Before, if it was in your plan and with stakeholder input, and this was, I think, in the last 2-3 years, you could do some substance use prevention with MHSA dollars. This one actually broadens it to where you can provide substance use only. So what I mean by substance use only is that's the only diagnosis the person has is for substance use, not a co-occurring. Because like I mentioned earlier, we have an FSP that does that. We have other programs that do that. Before, if you had only a substance use condition, MHSA could not be used. And under Behavioral Services Act, it gives you that option. So if counties have utilized or maxed out their substance use funds and some of the other resources that they have to treat substance use and still need services or they're at capacity or something like that, they would be able to utilize, if they have it in their plan, some of their BHSA to also address that. But it's not new funds. It's not a new bucket. It's just expanding those opportunities. We're not required to use Behavioral Services Act dollars for SUD. It gives you the option to, if we feel that we have a need for it, stakeholders feel we have a need for it, we think there's no other way to support it or fund it, then it definitely can become something that counties can put in their plan. And then Prop 1, also known as the Behavioral Services Act, does not affect other SUD funding sources. So it's not that the state is opening up Behavioral Services Act dollars to substance use because the other ones are going away. Now, all your substance use is still going to be there, the dollars. This just gives you additional options depending on what your local or county needs are. What it does change is before substance use was its own area and had its own reporting and its own planning, all of that will now be under one big county plan, the Behavioral Services Act plan, which will be things that are funded by Behavioral Services Act, but everything else, so substance use, all those things will be included in there, which actually allows for you to improve maybe your efforts for integrative care and making sure that you have true systems of care to where you can look at how you're leveraging funds, how you're braiding funds, how you're planning and looking at your continuum. So it does provide some additional opportunities to enhance and bring substance use into the mix and really do a better job with whole person, addressing the whole person needs. Reporting and oversight. So this is an area that impacts both us as the department, but also all of you as members of the system of care. There is going to be an increase in oversight for the funds, and like I said, there's going to be a new plan. The plan is going to basically require us to include everything that we're funding or receiving funding for into the plan. And if you're going to put all in the plan, you can't just list, well, here's 100 things we have going on. You want to, if you're having a plan, really look at how do these things complement each other. How does one build on the other? How does one allow step down? How does one support the other one? Where are places that we're duplicating things? And could we become leaner? And could we, improve, efforts by saying, hey, well, these two are doing the same thing. Maybe we can combine them and, utilize some savings from there to do something else. So that's the first bullet you'll see on the screen. Must report on all county funds, like I said. So we're going to need to look at the cost for every program and every cent that the county sends, which is fine, which we already kind of do, just not in one giant massive plan. We do it throughout the year and with different projects and different reporting requirements. How we're using those funds. So, what are they paying for? What types of services are they paying for? Is it for technical assistance? Is it for prevention? Is it for early intervention? Is it for substance use? What are we using it for? Is it for specific population? Is it to address a specific type of mental health condition? So we'll look at tying, what is the cost, what is the use, and then the last one, outcomes. And this is an area that, again, these are things that we've been doing, but because of the way our system and planning has been separate, there may be parts within the MHSA we're doing all this, but in another area it doesn't. You may have a grant of some sort that's pretty, what is the word I'm looking for? That may be pretty general in its reporting requirements, which is funny because that's how the funder's saying it, but now under this you'd have to be able to measure and still show what you're doing with that, which again I think will help improve the system of care, will help improve outcomes, will help improve experience, will help improve efficacy, will help improve cost effectiveness. So there's a lot of opportunities there. I would just say, and this is the part that's not just the facts, but just a little bit of opinion, is like it absolutely improves it. It's just going to be like, wow, we've got to wrap our arms around that to make it happen. And I think that might be a little challenge, just because, not that we're not doing it, but there's just so much going on, so many different facets and aspects to it, and to try to figure out a way of coordinating. How do I bring this all into one plan that makes sense? How do I tie them all together? How do I connect the dots? That's a task that does seem at times like Herculean, if we would say. But it is doable, and I'll say this: in Fresno, every challenge that's been thrown before us, we'll step up. We're like, what, we'll do it, we'll get it done, and so this will be no different. So it's like, hey, Sacramento, was this a challenge you just threw at us? Fresno accepts. We have accepted your challenge, and I'm sure our director Susan's like, please don't do that. Some of the benefits, I think, with the reporting and oversight creates increase in transparency. I shouldn't say not. We feel that the process has been transparent, but I think this reporting, consolidating everything into these outcomes and reports, makes it more transparent for the layperson, because they don't have to go track down like 50 reports and places to figure out what's going on. They'll be able to get that into more kind of one-stop shop. It allows our legislators and policymakers to go, well, we have 58 counties all submitting 58 different MHSA plans. They all do it differently. They all do their outcomes differently. Now you have those same 58 counties submitting an SUD plan. Those 58 counties submitting how they do some type of a, criminal justice reform plan. And so for lawmakers, it becomes really hard to make sense of what's going on. And it makes it hard for us as counties to really tell our story and the work we're doing and the work that our system of care and all of you are doing to actually meet the needs. So we're hoping this will actually create a more transparent, thorough process for people to understand what's happening. All the services need to be measurable. That's nothing new, but we need to really be able to have clear, measurable outcomes. Brian and we're having this conversation not related to BHSA today, but in general, like, well, what is our goal? And we're like, okay, but that's the goal. How do you measure that goal? And so we were even things that are not BHSA, just work that we're doing in the office on projects of like, we need to really become more intentional with our efforts, and so that we can really measure and understand what we're doing, and in our system will benefit. Looking at cost effectiveness, Again, not just for BHSA, but this will be with all county funded services. So this does require a lot more reporting, a lot more administrative and oversight. I know when we looked at what that would, the reporting and oversight requirements under Behavioral Services Act would require for the county, we looked at it, and in order to lift up that work, it's a significant number of additional administrative positions we would need. And I don't know if the if you know, with what we have with the Behavioral Services Act and what we're able to do with our administrative costs, we're going to be able to do that. I say that just to be cognizant of some of these things for you guys as system of care providers and contractors are also going to be impacted, right? You're going to need to be collecting the same data, collecting the outcomes, tracking your expenditures, really helping lean out and become efficient in your efforts, and that may require additional supports for you, and there may or may not be those additional supports. So I say that in a way to reiterate and I think acknowledge that, you know, we're in this together. It's not the county's doing this and you're going to do this. This is impacting all of us. So we've got to find ways to really be most efficient, effective in implementing this. Because if we fumble it and we don't do a good job implementing it, we'll recover from it, but we're going to be down a touchdown, right? And it's just like, and we don't want to be down. We'd rather keep possession, keep moving forward, keep scoring. So sorry for that football analogy for everyone who's like, I don't watch football, I watch soccer, baseball, whatever. The point is that we want to work together and make sure that, you know, we're really doing a good job of implementing this. There's going to be requirements for counties to have ongoing evaluation of service and programs. We've had to do that within our PEI component for some time, and we do that. We do pick certain programs to look at. I know our quality improvement team does those around audits and doing performance improvement plans. Managed care does those things with some great efforts. So these, again, are not things that are necessarily new, but they're going to be expanded and need to be more robust and applied to like every service. So it's just like, well, before only MHSA was having to do this, like, well, all our programs are going to have to do this, including internal programs. So this is not going to be, well, this is everything that we do. So everyone's going to be, you know, involved in this. We're going to need to be involved and conduct population needs assessment. So some of that work is going to be done with managed care plans. Some of that work is going to be done, for example, with public health departments, because they do community health improvement plans and things of that sort. And the good thing is while they're requiring those things to be component of our 3-year plans and our strategies, we don't have to go do our own, and which is great because then you don't have to be redundant and doing the same thing twice. It's like, hey, can I partner up with you guys, and how can we do together? So we do one needs assessment that the managed care plans and the county uses and our system of care versus everyone go out and do your own and then bring it back. And again, now we're trying to sort through 50 of these and make them into one versus let's do one together. So some new steps, some new ways that we need to coordinate and manage time and work collaboratively, and at the same time, it's going to give us a lot of better insight. We're going to have a lot better integrated plans. We're going to have a lot better way of coordinating care, and we're going to have a lot better, hopefully, results for the people we serve. So that's all a positive. More strategies and plans to address health disparities. So those are things that we've already been moving. What's going to be the new cultural competency plan requirements are really looking for counties to identify specific areas and disparities and challenges and develop strategies over time you're addressing. So those things are pretty consistent of where we've been moving as counties and what the state has been doing. And so with these 3-year plans, it's going to be, okay, you have mandated services and programs, and also how are you using these funding and these resources to address those needs and to reduce those health disparities and address your workforce shortage and address folks that are unhoused and address folks that are in crisis and get people to be able to step down and be able to achieve whatever their recovery and wellness goals are. And the last bullet point on that slide, and I'm not trying to read all these because most of you can probably see it for yourself, but in case you can't, that's why I'm going through them, because people could listen to this audio as well. But I'm trying to elaborate on all of them for you. The state has always had the option and the capacity to impose corrective action plans on counties and providers, and in certain instances, including fiscal sanctions. They were limited to specific projects, programs, funding, legislation, things like that. Under the Behavioral Services Act, it gives them broad option to apply that. So before it's like, well, we could sanction you for not complying with a component of your PEI, but it wasn't all your MHSA. Or if your MHSA RER plan report, annual revenue and expenditure reports, there I broke down what that acronym was, and you don't submit it, they could have sanctions. Did they do it? Were they going to be fiscal sanctions? Those are questions. Under care court, there's stipulations in it that if the court feels that a county and the system is not doing a good job or is really not effectively engaging in trying to implement and address care court efforts, it could sanction, including fines, stuff like that. So that mechanism has always existed in the state, but it was for this program, but not this one. Oh, it's these two programs, but not these three. With Behavioral Services Act, it's everything that's in your plan, which is everything you have money to fund, and everything you're doing is now subject to that. And I raise that just for all of you all to understand why some of the things that you see on the bullets above, why we're going to be looking at efficacy, why we're looking at best practice models, why we're looking at cost effectiveness, why we're looking at having all the data, because we need to do those things. Because if not, we all can have sanctions, whether they're performance improvement plans, which sometimes are just more work, and we want to do. It's like, hey, if you have homework to do and now you did something wrong, now you got to go write. I'm thinking Bart Simpson on the Simpsons, writing on the chalkboard whatever he's writing. Each episode. I will not do whatever. I will not get a PIP for the county. I will not get a. Instead of having to write that 100 times, we would rather actually be doing the service and improving the care. So that's kind of why we want to avoid those, and we also don't want to take what could potentially, in some years, be leaner than others, funding away from the county and have it go for some of the purpose, because we didn't really address what we could have done in terms of oversight and reporting and data collection and things like that. So I'm pretty confident in our ability working together collaboratively as a system of care to do that, because like any dollar that's lost has an impact. Because somebody will go like, well, I could have used that money over here to do something, or I could have served 50 more people with that money. So we never want to lose money because of something that we did that we could have avoided. So we'll keep working together and try to address those. And I think we're coming close to the end of this presentation. So next steps, if you were there Monday, I told you guys that the next step was going to be us recording this and putting this PowerPoint on the website like we now have, along with utilizing our FresnoMHSA.com page to provide updates. So as we get updates, we're going to do that. The next step that's not on this slide is we're going to take those questions that were asked last week or on Monday and try to do a response for those as frequently asked questions, and also make those available on this website. So maybe after you watch this, if you've got some questions, you can check on that post, or we'll probably put it on as a document. I don't know if we'll do a recording, but at least it's a document that you can go through and see kind of what the questions were and some of the responses to it. But these are the things that we're going to need to start doing sooner than later. Like I said, on paper it's about 24 months till this takes effect. In reality, it's less than 18 months as the way we have to operate. There's a lot of things that we don't know yet. There's a lot of things, if you have been listening through this presentation, that I didn't have details for you and said, those are pending. And so we are working with our associations, working with our county partners, working with the state organizations and agencies to try to figure out, okay, so we've got this legislation, we need to implement it. What does it look like? What do we need to do? Can you define this area? Can you provide us direction for this? So those are all things that we're doing. And as part of that, we need to evaluate and assess all our programs. That's not just prevention. That's not early intervention. That's all programs. Because we want to look at all of our programs and look at, what is our capacity to have all those programs? What are our abilities to sustain those programs? With the money that's allotted, and are they able to bill Medi-Cal? Are we able to braid funding? What does that look like? And then, looking at all costs. So it's not going to be like, well, these programs are off the table, because everything we're going to look at costs. Can we afford to keep those programs? What is our capacity to support those programs? Are they, reaching the intended goals? Are they having those measurable outcomes that we desire? Is the program, regardless of if it's doing great or not, is that program addressing a mandated area that we have to have under the plan? Because we can't not do meet mandates that are in legislation to address something that's maybe not mandated. So there's a lot of things that we're going to look at. We don't want to cause panic. We're going to take time and go through all of these and really try to help understand those. And part of that work is going to also inform our work in the future of how we design programs. If we need to redesign programs and services to make them more beneficial, by beneficial I mean more effective in terms of the individual that's being served. Is it more cost effective? Is it able to do more with less? Does it align with the new requirements of Behavioral Services Act, etc.? Talked about our work in state level groups. We're going to continue to participate in state listening sessions. We encourage you guys to do that as well. From the BH Connect, BH Quip, DHCS, DPH, Department of Public Health, all the state agencies will have different listening sessions, webinars, between now and implementation of Behavioral Services Act. Some are just to be informational. Some will be community input and listening sessions where they're looking for your input. But we encourage everyone to participate in those to try to stay in the loop. We are going to try to do more listening sessions with you all, whether they're community forums or an update like this, or even building in maybe some components into things like a director's update, or maybe it's in a newsletter or some other sort. But we'll explore ways that we can continue to disseminate information as it relates to Prop 1/Behavioral Services Act. As things become clearer, we have more definitive information on what it's going to look like and what we need to implement. And then we're going to continue to try to be transparent in community planning. That means, as information comes out, we want to find ways to get it to you. We will continue to have those community forums like we had earlier this week. We'll continue to try to post and share information as we have it, the best way we understand it. And we understand through this whole process, both developing a future 3-year Behavioral Services Act plan, but also implementing the Behavioral Services Act plan is going to be something we're going to do in collaboration and conjunction with you all. Because for those people that are not familiar, about 70% of the work and services that Fresno County Department of Behavior has is contracted out. We contract out with you all. You are our partners who serve our community, and so we're going to continue to try to be transparent and collaborative with you as we work to try to implement this Behavioral Services Act. And I think that's going to be the last one, so I'm not going to skip to the next slide because it's probably going to just show whatever's on the computer. But if you have a question, 2 things you can do. Come back regularly to this website, FresnoMHSA.com, and look and see if there's any new postings, if there's new information, if there's an FAQ, if there's an upcoming community listening session we have, if there's a forum. This is where we're going to place that information. Also, if you have a question and want to ask or get a better clarity, we really encourage you to come to the source. And by the source, I don't mean us because we're experts, but come to the source because we will then be able to reach out to other MHSA individuals in the know, whether it's at the state level, at the association level, at different ways, and try to get information to you all. But the last thing you want to do is go off of information that is hearsay. And the way you can do that is by reaching out to us at MHSA. So it's just MHSA for now. We'll have to change it in the future. MHSA at FresnoCountyCA.gov. That email will come to our team that leads the MHSA efforts. They will log it, they'll review it, see if they have an answer, and if they don't, they'll still let you know that they don't have an answer and they have to research it. But if we do have an answer, we'll try to provide it. And some of those questions may be things that we put in our frequently asked question posting for other people to see. Obviously, removing your contact info and things like that, but just, hey, question, and then here's a response so that everyone else can be informed. Other than that, we thank you guys for checking this out. FresnoMHSA.com, like we said, is a great page to kind of bookmark, so you can come and check it out. And also make sure you're following us on social media, Facebook, Instagram, because when we do have community forums or things like that, or when there's a new posting, we'll sometimes put that information out there as well, and that way to come to this webpage and to look for that information. Otherwise, thank you all, and we will continue to work together to implement Behavioral Services Act here in Fresno County. Thanks.